In the last lecture, we talked about anesthetic monitoring and making sure that our patients' vital signs were okay. As far as record keeping goes, we do need to make sure that we record all the drugs that are administered, including the dose weight, dose volume, concentration, as well as the time and route administered. So that would be all of your pre-medicants and anesthetic drugs, induction agents, antibiotics, anything along those lines that were given. Typically goes on what we call an anesthesia graph, which is one form dedicated to anesthesia. You can write it elsewhere in the record. It doesn't have to be on the same form as your vital signs, but it's useful to have all this information in one place. Now, as far as vital signs go, I have an assignment for you on the Arizona law requirements for monitoring vital signs, but they are fairly limited, fairly basic compared to what we should probably actually be doing. So it's best if we can to follow the AHA standards. And AHA recommends that we monitor every 5 minutes if possible, and that we do measure things in addition to heart rate and respiratory rate, like blood pressure and end tidal CO2 and the pulse oximetry reading the SpO2, and record that information as well. So it may depend a little on what type of practice you're working on. But every 5 minutes is ideal, with the understanding that sometimes we'll be busy, moving the patient or giving a fluid bolus or helping them in some other way, and it may not always be possible to do this exactly every 5 minutes. Remember that writing vital signs down does nothing to help your patient in the moment. It's very important that we have accurate medical records, but writing down that the patient has low blood pressure doesn't help them not have low blood pressure. And unfortunately, I do get medical records working in an emergency practice where the technician has documented for an hour, let's say, that the patient has had low blood pressure, and we'll have the patient in there for renal failure, and nowhere on the record does it say, okay, the patient had low blood pressure, so I turned the anesthesia down, or I gave a fluid bolus, or I tried my other drugs like dopamine or dobutamine, or I even informed the doctor. And so it's important that we not only write this stuff down, but that we actually use our thinking caps and we intervene and take appropriate actions when we see a problem. We also, somewhere on our anesthesia record, have to record the recovery status. This may be as simple as normal or uneventful, and most states, including Arizona, require a recovery log. So somewhere in your hospital you'll have an anesthesia log, or your computer system may generate it, and if someone from the state were to come in and say, let me see the outcome for all the anesthetic procedures you've done, you would have that recovery status noted there. So that's kept separately from the patient's medical record. This is an example of an anesthesia graph that uses a charting method where you're using a symbol to indicate each value. So heart rate here is a solid dot. We can see we start at about 110 and go up to close to 120, and then at one point we go over at about the 10, it looks like 11:20 a.m. mark there. We're at 130 almost for our heart rate. We have an open circle for respiratory rate, and there's these symbols or this key on the side. What's nice about this type of graph versus something where we just write down numbers is that you can really see the trends in the up and down. For instance, you can see at that spot at about 11:20 where the heart rate goes up, the technician responded by turning the isoflurane or that vaporizer setting up as well, which maybe makes sense in this situation. So we have a better idea of the average over time versus just writing down the heart rate of 110 or 120, and this really doesn't take that much longer as long as you're accustomed to using this. Other things we can see on this record, at the top we've got our pre-medication and induction agents, what we're using for maintenance. It looks like we've got some pre-op diagnostics there as well, and there's a comment section where we can say, yep, there we go, at 11:21 we had a sudden increase in heart rate and respiratory rate. The palpebral reflex came back, so we probably weren't in stage 3 plane 2 anymore where we want to be, so it makes sense that we would increase the isoflurane at this point. You can also see at the bottom they've noted IV fluid rates, and on the left-hand column here we've also got a place where we've documented our endotracheal tube size and our bag size, as well as our breathing system there. We should, in addition to vital signs, have information like our oxygen flow rate and also that vaporizer setting. Remember, inhalant anesthetic is a drug, and so we should be documenting how much we're giving and when. just like we should document the interventions we do for any specific problem that we see. Think about medical records, they're telling a story, right? So if this patient were to not survive this procedure, I don't just want to see, oh yeah, the heart rate suddenly dropped. I'd want to be able to say the heart rate dropped, but look at all the things we did to try to help. Okay, so very critical part of our jobs. You learn this in VA, but just as a reminder, if it didn't get written down, it didn't happen as far as the veterinary board is concerned, or as far as the law is concerned. But sometimes we won't have time to write things down right then. So if you need to jot yourself a quick note and go ahead and add it back later, that's okay. Our priority is still going to be helping the patient in the moment. We've been talking in very vague general terms about drugs we can use with cats. A lot of our discussions center around dogs, and we mainly work with dogs on campus. But there are some special considerations for cats and anesthesia that I wanted to go over. I do have an assignment for you about cat anesthesia specifically, because cats have a much higher death rate than dogs. So if we look at something like ASA status, we said at let's say a P2 level, dogs have about a 1.5% chance of dying, while cats at a P2 have a 3% chance. Okay, so cats have nearly twice the rate of dogs in most situations, and nearly 10 times the rate of human death under anesthesia. And that is not because cats are somehow special, it's because we don't do as good a job of taking care of them and of paying attention to them. And in general, we have a little bit of a bias in veterinary medicine towards the treatment of dogs. And I think partly it's because we communicate better with them. We've co-evolved with them. They grew up, around the campfire with us and helped us survive. And we just don't read cat body language as well as far as handling goes. But also when it comes to anesthesia, we don't monitor them as well. We're less likely to, let's say, hook up the ECG to a cat during anesthesia, and we're less likely to notice or pay attention to some of the problems they might have at times like recovery. So we first have to recognize we all have this bias. I'm a cat lover 100%, but in the clinic I have this bias as well with cat medicine, and there are specific things we can do to make sure we take care of them. So one of the special things is feline intubation. So as far as intubation goes, they have the same anatomy, they have the same structures that dogs do, but they are more likely to have some complications with it. So the big one we see is what we call laryngospasm. This is obviously a dog, but I've included this image here because it's a very good depiction of what we normally see. So on the right there, you can see the glottis on the bottom labeled at G, and on either side we can see those vocal folds. And the vocal folds are also called a retinoid cartilage. And in cats, sometimes instead of sitting open, like we'll see in this dog and in all dogs when we go to intubate them, these have a little muscular contraction we call laryngospasm, and they will snap shut. And no matter how hard we try to push that tube through, they will not open. We can't force them to be open. Not only can this happen when we try to intubate, but it can happen in the post-operative period when they're recovering or after extubation as well. And if you can't open those vocal folds and open your glottis as the entrance to your trachea, you can't breathe. So that's a big difficulty when we intubate them, and it's also potentially a big complication they can have in recovery. So what do we do to intubate cats? Well, the best thing to do is to put topical lidocaine, and they make a gel for this, or you can draw up a small amount of the injectable, usually 0.1 milliliters of injectable lidocaine, and before you attempt to place the tube, go ahead and put that lidocaine on the larynx where those vocal folds are, even if things look like they're open. And the reason we want to do that is so that we don't have to do trauma with multiple attempts when we place that endotracheal tube. Even if we think, yeah, I've got this, it's fine, I do it fine all the time, this reduces the chance that we'll have to kind of irritate the tissues by making multiple passes to try to get it in. And the other thing is that this can happen, we said, even in recovery. So using this lidocaine reduces the chance that after the patient is extubated, this will happen again. And I did mention when we talked about masks that sometimes it's appropriate to skip intubation for cats for short procedures because they are more likely to just have irritation as a result of intubation. And sometimes, taking this risk that we're going to do some trauma and potentially cause laryngospasm in the post-operative period and cause them to have trouble breathing, is it worth the reward for a short short procedure. Nonetheless, we always need to be prepared to intubate if something goes wrong. And this is not something I want you to be scared of. We do it all the time, but I would recommend you be comfortable with dog intubation and all the anatomy there, and then that'll make it easier when you kind of branch into cats. It's just a little bit harder, but it's not going to be terribly different. The other thing we sometimes do is use a stylet, which is just a rigid wire, and we place that in the endotracheal tube so that the tip is not quite so floppy, and it will go where we direct it on the first try. The stylet doesn't get passed down into the trachea, it just gets held to brace that endotracheal tube, and then we would pull it out as we advance the tube into the trachea itself. I've included a video in the playlist for you of this cool device called a V-gel. It's used for cats as well as rabbits for intubation, and it doesn't go into the trachea itself. It covers the opening of the trachea and it enters the esophagus so that the patient can't regurgitate, and that dead space is limited because we're still sitting just over the opening of the trachea without allowing gas to go elsewhere. So that is something that you might start to see in practice. They're relatively new, but they've become more popular in the past couple of years. They're more expensive than endotracheal tubes, but they're easier to place, and so that's another option we have for cats besides just using a mask. I just wanted to remind you again, with cats, we want to make sure, we want to be extra careful that we do know that the tube is in place. So we talked about making sure we can see it enter the glottis and we don't see it just disappear off into the esophagus. You want to give a breath and listen to both sides of the chest. We want to see that the reservoir bag and the unidirectional valves on the machine are moving. If we hook up our end-tidal CO2 sensor, we want to see that's in a normal range. If it were in the esophagus, if it were in the stomach, it would be 0. And so we know we're in the wrong place. But it's extra important with cats to make sure that we do have the tube in the right place, because it's a little bit easier to end up in the wrong place. With that laryngospasm, things close off at the last minute and your tube doesn't go where maybe you think it will. When we talked about pre-medication, we talked about how helpful it is to reduce anxiety in our patients so that they don't have stress hormones like epinephrine circulating that affect their heart rate and blood pressure while they're under anesthesia. And with cats, this is even more critical. So we can do things like use towel wraps for restraint when possible. Some cats like to have their faces hidden under the towel, some don't, but it seems to be less stressful than scruffing. Of course, giving drugs so that we're not trying to do things like placing an IV catheter in a patient that is unpremedicated. I don't know what the word is for that. But, Kitty Magic is one way we achieve that. We give that one intramuscular injection instead of multiple injections like we might do for a dog. And then another real simple thing, they've done studies about this, which I think is mind-blowing, is just boxes. For a cat that is in the hospital, maybe awaiting the procedure or alert enough to move around after the fact, having a box, it can be a cardboard box or an empty litter box, definitely reduces that stress level. Of course, things like not being super loud and not having them where they can see dogs. Use common sense, but sometimes we have to be a good patient advocate and take that little extra bit of time to think about what's going to be helpful for them. I mentioned our bias in practice against cats, unconscious bias. None of us set out to hurt cats, but one of the ways that this is very clear is that cats are a lot less likely to receive adequate pain medication. So we like buprenorphine because cats are not as likely to get agitated with it. We call it dysphoria when they're agitated, angry, confused. We also see with some opioids like morphine, they might be excited or their temperature might be elevated, and we tend not to see those things with buprenorphine, but it may not be as effective for severe pain, and so sometimes they do need other drugs, or they need things like fentanyl CRIs, and we tend to kind of forget that that's the case for cats. So being a good patient advocate again. I think the other reason this happens is that we're less tuned into their pain signals. The AVMA came out with this study, I think it was in 2018, about cat pain signals. So dogs are pretty obvious for the most part. They cry, they whine, they look sad. We can tell just by looking into their eyes or looking at their facial expressions. Cats are more likely to do things like be aggressive, and it's hard for us to be sympathetic to the cat that just scratched us in the face. One of the things they looked at for this study was how cat facial expressions might be different. So the cat on the left, it looks really alert. We would say he's probably not in pain. Cat in the center, we see the ears are lowered, the whiskers are lowered. We have moderate amounts of pain. And then the cat on the end there, with its eyes kind of closed, its ears are down, whiskers down, we would say is in severe pain. But to someone who's not tuned in, or if you haven't worked with cats a lot, it just looks like, wow, he's sad, right? Or he's grumpy, he doesn't want to be here. So this is something we just have to continue to learn about and be extra aware of. You might have to be that person that says, yeah, I know the cat got buprenorphine, but I really think he's still uncomfortable. Can we also give something else after surgery? A few other basics for all of our patients that we haven't covered yet. When possible, if we're moving a patient, you want to disconnect the endotracheal tube from the breathing circuit and then reconnect once we're at our destination. That's assuming we're just moving from one table to another and not down a long hallway or something. Leaving the endotracheal tube connected to the circuit and trying to move that with the anesthesia machine, we're very likely to, maybe we go too fast with the patient or with the machine and the tube gets out of place and we do serious damage to the trachea. So it's usually not worth the risk. We'll talk and practice more about carrying and positioning, but remember, even though they don't feel anything because they're under anesthesia, we don't want to do anything that's going to be painful or uncomfortable for them when they wake up. So we're not tightening the restraints down on their legs so they're like on a little, kitty or doggy torture rack, especially for patients that say have hips that maybe aren't super comfortable, older dogs, larger dogs. If we pull those hips real tight, they're going to wake up super sore. I just always think about going to the dentist and you have your mouth open for a long time and you go home and your whole jaw hurts, even if you haven't had any work done. And that's simply because you just have that tension in your jaw for an extended period of time. And it's the same for the limbs. So we're not pulling them super tight. We're just generally securing them to the table to help keep the patient from moving back and forth. Especially for our smaller patients, we need to make sure we're not laying instruments across their chest or our clipboard or leaning on them. That becomes tempting with things like dentals where we're having to lean over the patient. We kind of don't notice that maybe we're compressing their breathing. If they do have any issues with their lungs, if let's say we know they have pneumonia on the right side, we'll want to keep that right side down and leave the good side up if we can. So the right side would be touching the table if it was the diseased lung. And that's because we know we're going to get some degree of atelectasis, right? We see some degree of decrease in lung function no matter what, and we want to keep the good lung working as well as possible, if that makes sense. If we need to tilt the surgery table for any reason, sometimes particularly for spay procedures, the doctors find it helpful to angle the patient with their head towards the floor and the tail kind of in the air. And in that situation, it makes it easier for them to find the uterus and ovaries, but it slides all of the abdominal organs towards the diaphragm, and then the patient can't breathe well. So if we do have to tilt the table, it should be short periods of time. And then it's my job as the technician to say, oh, I see that you found the uterus. Are you okay if I go ahead and put the patient level again, adjust the table so they're flat once more? We will put artificial tears ointment or drops in the eyes when we start the procedure, and ideally every hour or so after, because they're not blinking. We don't want them to wake up with dry eyes or painful eyes or develop a corneal ulceration as a result of the surgery. When we talked about induction, we said it's one of the most dangerous periods of anesthesia when we're likely to see things like big drop in blood pressure or respiratory apnea. Recovery is the other highest risk period, and this is when we tend to disconnect all the monitors and kind of write stuff down less, pay attention less to our patients and during the procedure itself. So you want to have this in your brain so that you know that recovery is a time that we need to be even more attentive. We don't have the benefit of machines beeping at us usually, and this is one of the times that we're most likely to see a true complication or life-threatening issue. So the process of recovery begins when we turn off that inhalant anesthetic. So when I set my vaporizer to off, we may also be reversing agents like dexdomitor with our antipomazole, our antecedent, during this time. And there are 5 specific criteria that tell us when the anesthetic period is over. Is that 5? 1, 2, 3. Okay, wait. There are 4 specific criteria. I'm thinking of signalment, right? Signalment is 5, recovery is 4. It's important that we know these criteria. I'm going to test you on these criteria. I'm going to require that you know them to successfully complete this position on live patients, because we have to know when the danger is over. And until our patient has met these 4 criteria, our patient's still in danger. We're still in that high risk period. So I think the first one you guys knew, it's when the patient is extubated, right? When they have a normal temperature. So I typically define this as anything above 99. We don't need to be like at wherever we started. We might have started at 101, but if we're at 99, we're probably good to go. Able to maintain sternal recumbency, so we can sit up, at least for short periods, and walk. We don't need to be walking like, things are amazing. We can be drunken walking, we can take a few steps, it still counts. But when we've met these 4 criteria, we're out of that high risk period, and we know at that point we don't need to continue to monitor. How long is our patient going to take to wake up? It tends to be that the longer they were under anesthesia, the longer the recovery will take. So if your patient's been under for 20 minutes for a very quick spay, oftentimes we're going to be up 10-15 minutes good to go. Obviously, we have to take that time to metabolize the inhalant out of our system, and any other drugs that are on board that might be keeping us in that anesthetized state. But in general, we wake up pretty quickly if the procedure's short. Longer procedures, I have a patient under anesthesia for 3 or 4 hours, I might be looking at 30 to 40 minutes. That's not unusual. Now, the health of the patient. Remember, we said that with liver disease or liver dysfunction of any kind, our drugs take longer to metabolize, and we're going to take longer to wake up. Same thing if we're experiencing something like hypoglycemia. We're going to take longer to wake up. So keep those things in mind. Being cold is another big one here. If we are cold, everything in our body has slowed down metabolically, and the drugs are going to circulate out of our system more slowly. So that's why part of what we do during recovery is warm patients up if needed. So what should we be monitoring during this period? So American College of Veterinary Anesthesiologists says we should be looking at the respiratory rate, mucous membrane color, and capillary refill time. Of course, our heart rate or pulses, whatever we can feel well, making sure those feel strong. We typically don't monitor blood pressure during this time unless we've had a problem during anesthesia itself. So other measurements is indicated by the patient's status. If I was having trouble breathing and I was having some kind of respiratory distress during the procedure with a low pulse oximetry reading, a low SpO2, I should probably be checking that after the fact. Same with blood pressure. I don't want to pull up a medical record and see, oh yeah, the blood pressure was low the whole time. Well, did it get better when he woke up? I don't know, we never checked. Okay, that's not acceptable. Of course, we'll measure the body temperature as we go, and we'll note if we apply any warming. So if we use something like the bear hugger or the hot dog or heating disc, I'm going to go ahead and record that in my medical record. And then observation of behavior and signs of pain. So on campus, we do have a pain scale that we use that you'll get before we begin our procedures on a scale of just 0 to 4. 0 being no pain and 4 being extreme pain. But we need to make sure we're noting that, and if necessary, giving more pain medication. Just because they got drugs at the beginning doesn't mean we don't need more analgesic here. That's kind of what I learned, or what we used to do, is that, well, he got an injection when we started. You can't just give him another one. Yeah, you can. So that's something that we sometimes need to ask for as well. In a perfect world, we'd have a trained technician and veterinarian with the patient continuously, dedicated to just that one patient. This is not always possible. If you're in a high volume, like a spay-neuter clinic, you might have, 5 cats you're recovering from anesthesia, or multiple dogs, and you're just kind of lining them up in a row and looking for signs that they need to be extubated. What I would encourage you to do is that if you have a patient that's ASA status 3 or higher, which is a lot of our dental procedures, mass removals, orthopedic surgeries, depending on their health status, that's the time for sure that we want to have somebody just with that patient. Those are the patients that are going to be more likely to have an issue in this period as well. So, you might be okay with your P1 or P2 patients recovering a bunch at the same time. Not ideal, but better. But with the P3 patients, definitely we don't want to do this. And if you can't be with that patient continuously. Let's say the patient's extubated. A lot of practices, once they're extubated, they want you to go do something else. We should be checking on them at least every 5 minutes. And that doesn't mean I need a full TPR every 5 minutes, but I need to be visually taking a look, making sure their heart's beating, they're breathing, if they're breathing, their heart's beating, and making sure that they look okay, they don't need help, they're not in pain. Typically during this period, we'll record vital signs about every 15 minutes. We're not going to see things like temperature change dramatically more quickly than that during this period, so 15 minutes for recording is fine, but I need to at least look at them even after they're extubated every 5 minutes. So our role, we said we would discontinue the anesthetic agents. We usually do like to give oxygen in the postoperative period, so when I turn that vaporizer off, I will leave the oxygen on for about 5 minutes. We do this so the patient gets the benefit of a little bit of extra oxygen, but it's also nice because if we leave them connected to the anesthesia machine with the oxygen flow on, they start to exhale that waste gas, that ISO or that SIVO, through the machine, and it gets filtered out through the scavenger instead of into my face as they're waking up. So keep that in mind too. If you have patients that did have some respiratory distress or even are shivering severely and need extra oxygen to their muscles, we can do things like just put the tubing in front of their face for oxygen. We can use a little e-collar with, sometimes people put saran wrap over it and put the oxygen tubing in there. So we can give oxygen postoperatively if needed. And then we said giving reversal agents like our antecedent for our dexdomitor. Of course, documenting all this stuff too. We are going to gently and calmly sit with our patients. I really like this picture here because she's not sitting on her butt, right? She's kneeling so she can lean forward so she can be responsive to what the patient needs. Maybe she could give him a little pillow instead of holding his head up, but it's nice to be able to not have to worry about, oh God, what if he needs something? I'm not that good at getting right up off my butt and helping them. So I really want to see you in an action technician position here. We'll make sure everything is untied. I'm always the one that forgets and leaves something attached, and then I drag the very expensive ECG monitor with me or something, and getting help to move the patient so that they don't start to struggle and fall down here. So calm, gentle, quiet. I really, really recommend that you put a blanket over the patient, something fairly weighty but not, that's going to restrict their breathing, and they get that kind of snuggled or swaddled feeling. And I find that that smooths out to some of what we're going to see as the patient starts to wake up. So, hasten recovery with gentle stimulation. What is appropriate to do with our patients in the postoperative period? Well, for one, nothing you wouldn't do when they were awake, and nothing you wouldn't want done with you. So beating on their chests, rubbing them vigorously, these are things that do not cause their liver to metabolize drugs faster. There is nothing about that kind of stimulation that is helpful. In fact, what we see is that sometimes it rouses the patient prematurely. So they're not really awake, but we've beat on them enough that they lift their head for just a second. We pull that endotracheal tube, we walk away, and then, nope, they really weren't ready. They're really not swallowing on their own, except when we're beating them. And it wasn't safe to pull the tube yet. So that is not an appropriate thing to do. And imagine how you would feel if you woke up that way. So gentle things, nice doggy, okay? You can pet, you can stroke, you can talk to them gently, but we're not yelling, we're not bicycling the legs like crazy. It is a good idea that every 10 minutes or so, 15 minutes, if the patient's not moving around on their own, that we roll them over. And that's to prevent atelectasis, but also just the blood pooling on one side, which is hypostatic congestion. So that's not a bad plan. I don't typically do that if they're already kind of starting to wake up, but if they just seem completely out of it, it's a nice thing to do. Any warmers should be placed centrally under the heart, and then, as we said, giving analgesics as needed. We have an IV catheter in place in case of emergency, right? And we just said that recovery is one of the highest risk periods of anesthesia along with induction. So we will not be taking that catheter out until the patient has met our 4 recovery criteria. I know sometimes in practice we pull this out because, it's convenient because the patient's asleep, but this is the time that we need it the most. Okay, so this is not the appropriate time to pull it out. Maybe if we have a super fractious cat, something along those lines, but otherwise it has to stay in. That was the whole point, was to have it in so that we could give emergency drugs if needed. this is one of the times we're most likely to need them. Please use common sense here. All right, so we're going to maintain a patent airway and extubate when appropriate. This is kind of a funny picture. This patient's already been extubated, but bulldogs have all this excessive soft palate tissue, and sometimes after you extubate them, they can still have some issues. So this was one solution to keep him from, I guess, having to push through his lips to breathe. He probably just should have kept the tube in a little bit longer, but let's look at how we know when they're ready. So extubation. We're going to keep that patient on oxygen for about 5 minutes. We said rotate periodically, the patient, not the tube. But before we are ready to pull the tube, we will want to make sure that it's deflated. So don't untie it until we deflate it. If we were to untie it, let's say without deflating it, there's a chance we could accidentally pull it while it was still inflated and do damage to the trachea, and that would not be good. Now, how do I know when it's ready to pull? Sometimes we learn when they've done 3 swallows, and then we sit there and we count. Okay, he swallowed once. All right, 5 minutes have gone by. He swallowed again. That's 2. 3 more minutes have gone by. Swallowed the 3rd time, and you like pull it out and run away like it's some sort of relay race or something. So that's not what we want to do. We want to see that he's consistently swallowing, and that may be lifting his head, licking, and blinking very commonly go along with this. But I would much rather you leave the tube in too long rather than pull it out too soon. Okay, so he should be consistently licking, consistently swallowing, and then I know I can go ahead and pull it out. Now, if I leave it in too long, he could chew it off, but I'm sitting right here. That's not going to happen. Okay, I'm just going to untie as I start to see those signs of readiness after I've deflated, and then I'm going to pull the tube straight out once I see that he is licking and he's roused. So I did mention bulldogs and brachycephalics in general. We tend to wait a little longer to extubate, and that's because they do have this extra soft palate tissue in their larynx. So the soft palate's like that roof of your mouth, and in them it kind of hangs down and it covers the opening, it covers the glottis, and they have trouble pushing air through there normally, and that's why you get that sound. And this is true especially when they're sedated and waking up from anesthesia. So we'll typically leave these tubes in a little longer. You can see this pug's just walking around with it in, kind of like the pug in the last photo, and that's not uncommon. They tend to kind of like it in there. So I'm, on these guys, going to wait an extra long time since they have to do this extra work to breathe. So obviously this is a funny picture, but this is called strabismus, when our eyes don't point in the same direction. And from time to time, we do see, as patients recover, that we can have complications related to cranial nerve function, so that our brain doesn't reboot properly. Have you ever had that issue with your computer where you turn it on and you get like a weird blue screen for some reason, so you just restart it and then everything's fine, and you don't know why that happened? It's kind of the same here. So remember that the cranial nerves control things like swallowing and licking, but they also control the position of our eyes and our reflexes. So this is something that you may see during anesthesia, and I've posted a video in the playlist of a cat that wakes up with nystagmus from anesthesia. That's the oscillation back and forth. Usually these complications are pretty short-lived when they happen. We would want to note them in the medical record and let the doctor know, and it's kind of alarming to see, but for the most part they resolve within about 24 hours, if not sooner. Of course, we would just need to let the client know what was happening and make sure that everything else was okay. So it's normal for our patients to experience all of the stages of anesthesia in reverse, and this is where we typically see stage 2 the most. Stage 2 is our excitement stage, where we may struggle or flail or even vocalize and have rigid or stiff muscles. During induction, we usually go through that pretty quickly and get on to stage 3, but it may be more prolonged as we're waking up. Now, it's normal to have a little bit of crying or struggling at first, but stage 2 should be very brief. Once we're at stage 1, where we seem alert and we're looking around, we should not still be crying or struggling, and if we are, we may be in pain, or we may be dysphoric. We may be having a reaction to the opioids where we just feel like, oh God, where am I, what's going on, I've been abducted by aliens. I went to a really good continuing education seminar on pain control. What they said is if you have a patient in this state, maybe they're more painful, maybe they're having a reaction to the pain medication, but the best thing to do is to give them pain medication. And if they look better, then the problem was pain. And if they look worse, then the problem was that they were having a reaction to the pain medication. And remember, we can reverse it. With our opioids, we have naloxone as an option to reverse these things. Or we even talked about using butorphanol as a partial mu antagonist that will reverse some of the effects of our opioid agonist. So that's an option too. We often make the mistake, though, of instead of giving more pain medication, giving just a sedative like acepromazine, and that will make your patient be quiet, but it's not going to have any effect on pain control. So remember that. And remember, it's better to treat for pain first and ask questions later. It's not normal. And you may have seen this in your externship, but it is not normal for patients to just cry and struggle and flail in recovery after surgery. Okay, those patients need our help. There's some other complications we need to be on the lookout for, or we need to be careful to prevent. Certainly making sure the tube doesn't get accidentally pulled too quickly while the cuff is inflated, or roughly handling the patient, letting them fall on the floor, dropping them. This usually happens because we want to be a hero, and I don't need help carrying this dog, I can do it. Well, it's not worth it. Okay? It's not worth the risk to the patient. It's not worth the risk to you getting injured. So ask for help. No one's going to think you're weaker, and if they do, go work somewhere else. So gentle, be careful with these patients. If you're carrying a patient, they start to struggle and you're in trouble, just set them down on the floor, and you can always get somebody to help you move them around from there. Regurgitation, we worry about at any point, but it's especially likely during induction and recovery. And remember, the patient doesn't have to be conscious. So regurgitation is not the same as vomiting, where we see retching. Regurgitation is just the stomach kind of passively, those contents coming up into the esophagus. And just the fact that everything's relaxed and that cardiac sphincter and the opening of the esophagus to the stomach is relaxed, things can just kind of start to come up. So if you do see in the patient's mouth any evidence of fluid or food, the best thing to do if you can is quickly hang their head down. If it's a big dog, you might hang their head over the edge of the kennel or the table. A small dog or a cat, you might kind of pick the whole patient up and hang them at a 45-degree angle so we can get those contents out. If you have somebody to help you, getting like a bulb syringe, one of those booger suckers, and sucking any kind of food or liquid out of the airway is a good idea. Make sure you don't get bitten. If the patient's not awake, that's not going to be an issue. If the patient's really unconscious, it's nice to take some gauze and swab the back of the throat, make sure there's nothing back there, and ask your doctor. But sometimes what we'll do, if we know the patient has regurgitated, is leave the cuff of the endotracheal tube slightly inflated, and then as we pull it, it'll sweep the airway of any of those contents. But always communicate, let somebody know it's not your fault if this happens, but use common sense and try to get as much out as you can. I talked about dysphoria versus pain versus excitement when we talked about our stages of recovery, but again, it's not normal for us to struggle or cry for a prolonged period. I do find that it depends on the breed. So puppies, right, they're a little more sensitive to start, they're more likely to cry from an injection, and they're more likely to cry when they wake up. Doesn't mean they don't need help. Okay, it just means we're more likely to see that. Same thing with small dogs or Nordic breeds like our Huskies, right? I had a dog in recovery, a Husky, who jumped up into the side of like a big cement kennel and broke a canine tooth in recovery just because he was so agitated. Was he painful? Probably. Was he being just a Husky? Probably. And so sometimes we'll use analgesics, but also sedatives or even like a small dose of dextrometor to help smooth things out as he wakes up. But it's not okay to just leave him in there struggling and crying and freaking out. I don't know how many times I'm going to say that. Should I say it again? No, you got it? Okay. All right, some more serious things that we can potentially see are, of course, respiratory complications. It's pretty unlikely that, my heart's going to stop all of a sudden, or I'm going to have issues with my blood pressure because usually my drugs are wearing off. But we can certainly see things like laryngospasm in our kitty cats who've been extubated. I mentioned that's a complication that can occur at any time, but even after the tube is pulled. This is likely if we haven't met those other recovery criteria yet. With patients, let's say I've got a little bit of kennel cough or something, I might end up with some mucus in my airway and have that, be an obstruction to breathing. So that's why we're hopefully monitoring continuously, or at least looking every 5 minutes. And we can see buildup of fluid in our airways, especially if we got too many fluids. And so if you see coughing in the post-op period, or you're listening to the lungs and they don't sound clear, make sure to let somebody know. You can always put a pulse ox on the patient too. If you're concerned and you have to walk away, you can stick a little pulse oximeter monitor so you have something on there that's keeping an eye on things. Or, you know, be creative. Maybe you have a patient that's recovering, like a cat that you're concerned about and your kennels are kind of far away from your treatment area. Can that cat go in a kennel and sit in the treatment area with you so that somebody can be with him? Maybe you're being extra cautious, but I think that's okay. That's what I'd want somebody to do for my cat, right? We talked about how having liver function that's not as good will delay our recovery. There's not necessarily a ton that we can do about this other than make sure they continue to get attention during that post-operative period and give reversal agents if they're available. Recovery is also impacted by blood sugar, and I do find that sometimes if I know they have a liver issue, or I have those pediatric patients. Remember, pediatrics have livers that are not necessarily fully developed. Sometimes just giving a little bit of dextrose IV, or you can also give dextrose on the gums, and it will just absorb through the mucous membranes. That will help with recovery a lot. So that's something to ask about. If you have a patient that's just not waking up for a long time, you don't really know why, we don't have to check the blood sugar. It's not unsafe for them to get some glucose even if the blood sugar is normal. So ask, hey, can I just take a little bit of dextrose and put him on his gums? You might see a big difference. I've seen it a lot. Hypothermia, of course, we want to use those warmers on our patients, central rewarming. But remember, we have to go back and check their temperatures every 15 minutes. They can very easily get too hot. So that's on you. If you are, let's say maybe I have to go to lunch or something, somebody else needs to be in charge of that. Not like, hey, will somebody keep an eye, but like you, Susan, you are checking the temperature when I go to lunch, yes? Okay, so be responsible for that.